The biggest problem is calcium, because when there is calcium, the prognosis is always worse, because the calcification reduces the artery compliance. So this means that we have higher rate of acute angiographic complications, such as dissection, perforation, slow or no flow at all, distal embolization, and recoil. Heavily calcified arteries may be difficult to dilate with conventional angioplasty and poorly respond to DCB. High pressure balloon on the other side can be of insufficient force, but also can damage the artery itself. How can I go back? Okay. So what is the limit? So we have a poor angiography result and elastic recoil, we have residual stenosis, we have flow limiting dissection, and we have complication when we work with just with PTA. So this would lead to a systematic use of stent with higher cost and more potential inflammation response. It doesn't move. So we need a vessel preparation for those cases. And how we can do that? We can work on the plaque modification itself to improve the vessel wall compliance, and we can do it with scoring balloon as a chocolate system or a standard scoring balloon like angiosculpt. We can do it with the old-fashioned cutting balloon, and now we have also intravascular lithotripsy. So this is a case, as an example, just to know how all these tools can help us. This was a patient with an occlusion of the VSFA, some lesion of the popliteal artery, lesion of the tibial artery, and occlusion, in particular, of the distal posterior tibial artery. And it was a Rutherford 5, so there was need to work on this patient in a wall artery system of the leg. So we started above with a standard PTA, but the result was not enough with a 6 millimeter balloon. So we moved to a scoring balloon, in that case a vascutrack. So we changed the sheath according to what was requested. We performed the angioplasty, and then was absolutely not enough again. So we decided to implant a stent. In that case, in a superior stent, according to the location of the stent, we perform a predilation with a 6.57 millimeter balloon, and we implant a 6 millimeter supera. And that, with all this work above it, was the only way to deploy the stent in a proper way. I will show you in a second. We perform also kissing balloon of the anterior tibial artery and the tibioperoneal trunk with a good result, 2.5 millimeter. And we deal with the distal occlusion of the posterior tibial artery with angioplasty at 2 millimeter with a good result. And what was really important to underline this case is that only thanks to a good vessel preparation we could achieve the implant of the supera in a good way with a good morphology of the stent at the follow-up. As you can see at the follow-up control, so where the stent, there was enough stent that we achieved with vessel preparation that allow us to have a good deployment, in particular good distribution of the net of the stent in front of the calcification. Also in the flexion position. And this was the control, so you can see how was good the work that we did with our scoring balloon and all the PTAs of the stent. It's fully deployed inside of our artery with a good flow. But when it's not enough, then when it's not enough, we can have work on the debulking. So we don't just compress what is inside the artery against the wall, but we start to remove it. There are so many atherectomy systems. We have also laser atherectomy. I don't want to spend many words about it because my colleague after me, they're going to talk in particular in the details of all these debulking systems.
Why then atherectomy system?
So in general, sorry, there's a sound maybe. What they do actually, they just remove the plaques, so they can work in an eccentric way according to the type the way they have been built, and so they remove the plaque. And why I started using that? This was a case that I performed in April 2020 in a patient former smoker with hypertension, diabetes. There was she has a Rutherford 4 classification with multiple SFA stenosis and an occluded anterior tibial artery. That was the lesion, so you can see they were very calcified, a short lesion. And we started with a PTA. And the result if you compare it to the beginning, it was quite improved. And then we decided to stop. But a few months later, she had a recurrence of symptoms. She came back with the same situation. And as you can see, the situation was even worse than before. So again, this time, we think that it's not enough with what we did before. Just few months, and then the result was still gave us such left us unsatisfied about what we achieved. So we went for a debulking system. In that case, a jet stream. Since there was you have already an occluded tibial vessel, we decided to use a filter distally to avoid distal embolization. We could, as you can see, we could remove partially the plaque. We perform PTA with a drug-eluted balloon, and that was the result. So without a stent, we could achieve really good work. But again, there's not all the situation required the same system. So this was another case, a female 83-year-old with hypertension, Rutherford 5, SFA, and popliteal obstruction. So in this case, the plaque was concentric, and then we said, why we don't use something different, something that can be very low, poorly traumatic, but we can achieve a good result all around the circumference of our vessel. So we went for an orbital atherectomy system with a small crown. We perform, after the debulking, dilation with drug-eluted balloon again, and this was the result. So this time, no stent needed. But how we really know that we are doing a good job with these devices? Well, all the studies that are reporting data about a device, they are usually supported by companies. They have some inclusion and exclusion criteria. They go selecting a particular population of patients, and usually the CLI patients are not included in this population, and when they are not absolutely excluded. So we have limited evidence of what we have. So running over all the publication about this kind of device, I found this study, after years, is still of interest in my opinion, because it was a prospective observational multi-center study focused on endovascular device intervention in patients with symptomatic PAD. It included any FDA-approved technology. This is a study performed in US with 4 core laboratories, and more than 1,000 subjects were enrolled in 51 centers. And then point was to check how it was the procedural and lesion success according to the device was used, the major adverse event, the quality of life of the patient, and then also an economic analysis. What was of interest, that patients from Rutherford 2 to Rutherford 6 were included, and the lesion was located all along the limb. So we had a femoropopliteal lesion, but also very distal located lesion. As you can see, there were many patients with chronic total inclusion. So in the 2-3 Rutherford category, more than 400. In the 4 and 5, also more than 500, and almost half of the patients Rutherford 6. And also the below the knee lesion, they were well represented in all the group. And the total outcome, they were actually good, with a high freedom from major amputation and 3 years for 2 and 3 classification, 4 and 5. And also 6 show similar result, in particular with the freedom from target lesion revascularization at 3 years. And when the study was also focused to see what we as physicians are using in different lesions, it was seen that balloon and atherectomy were the preferred device, and in particular the orbital atherectomy device was the preferred, most probably because it can work all along the circumference of the vessel. And in the in patient Rutherford 6, most probably because the lesions, they are located very distally and we cannot reach them with a bigger device, we use some instrument delivering a local force, or the scatting balloon. And bailout stenting was significantly less, again, in the group of Rutherford 6 because, when compared to 2 and 3 and 4 and 5. There was seen also a healing wound along 2 years during the follow-up. So it was really improved also, then there was an improved reduction of the number of wounds that were present. And also the quality of life were improved for all the patients, in particular for those with Rutherford 6. I don't know why he's living of his own life. This is another case with a male, 72 years old. There's something that is moving. Again, there was Rutherford 4, right limb, right lower limb, right SFA distal occlusion, very calcified. In this case, we went for a completely different device. Again, this is a vessel preparation system, not the bulking in this case, but it was working with pulse wave. You have seen it before this morning. You will see it later on again. That is working on the helping us to crack the plaque at all the level of the vessel wall. And it was nice to achieve a good result, always in addition with drug-eluted balloon. So in the end, what we can say that in chronic limb ischemia, the goal is not only to restore the flow, that is actually one of the most important goals, but also deliver sustained results, something that can stay longer than our procedure or just the day after. So you don't have to be, never be satisfied of the PTA, the result of our PTA. I learned it on myself, because the result can be just temporary and subject to recoil in very short time. We need to work on the vessel preparation. We need a randomized controlled trial to know which technology they really work and they are worth our money. But I think, and we can all agree on that, that modification plaque and debulking is something that we have to focus on to obtain better result. Thank you.